Hello and welcome to The Vaccine. I'm Jeremy Fernandez. As Sydney marks 5 weeks in lockdown, case numbers continue to worry authorities. Coming up, we take a look at how the outbreak is spreading across the city, plus the serious long-term effects for sufferers. Well, National Cabinet has met to discuss modelling aimed at determining what's needed for Australia's borders to open. Infectious diseases experts at the Doherty Institute were asked to lay out vaccination thresholds for avoiding future lockdowns.
We will get to the next phase when Australia reaches 70% of the eligible population who are double dose vaccinated. We will get to phase C when we hit 80%. Now, these are targets for all Australians to achieve. States, territories working together, communities working together, individuals, GPs, pharmacists. Australia will get this done by working together.
It comes as the New South Wales government continues to appeal for more vaccine doses as it grapples with Sydney's COVID cluster. Let's go to Casey Briggs now with the latest figures. Casey?
Well, Jeremy, cases keep climbing. We're really yet to see any significant bending in the curve of this wave, unfortunately. And the hotspots, or the hot region, we should probably really call it now because it's getting so big, it's just growing incrementally bigger and bigger. Here are the cases in the initial southwest Sydney hotspot. That's Fairfield, Liverpool, Canterbury, Bankstown. Then the second set of hotspot LGAs that were declared, and now the third one of Campbelltown, Georges River and Parramatta LGAs. And cases are still really growing across all of them, including the rest of Sydney combined. What we've seen this week is some more measures announced by the government that really just focus on compliance and enforcement. New powers for police, bringing in the Defence Force to help with some of the compliance operations in southwest Sydney, and some new rules not based on health advice, really just based on making it easier for police to enforce the rules. Masks outdoors at all times in those concerning LGAs, plus a 5K movement limit. So evidently the government's really hoping that if they can get more compliance, if they can get more understanding and following of the rules, you'll put an end to some of those big super spreading events we're still seeing, like the wake at Pendle Hill, where a lot of people have been infected. And it goes without saying, if those big events which contribute quite a bit to this curve can come to an end, well, then you're going to see this wave, you've got a better chance of seeing this wave die off sooner. What we're not seeing is anything this week that will directly target where the transmission's happening, and it's largely workplaces and homes. All of the eggs this week have really been in the compliance basket for the New South Wales government. The other thing that the Premier is counting on is a rush on vaccinations occurring. Friday, we've seen a record number of doses administered in the country. This is a record we thankfully keep breaking regularly, several times a week now. 210,000 doses were administered on Friday. 40% of those were in New South Wales, which is really continuing to pick up the pace of vaccinations. More than 60,000 doses going into arms every day in New South Wales at the moment. Per capita, New South Wales and the ACT are seeing vaccination rates proportion to their population much higher than the rest of the country at the moment. Here's how every state and territory is on their vaccination rate at the moment among those aged 16 plus. And as we say, the rate has been picking up quickly in New South Wales. 2.6 million people now have a first dose. If we see the pace that we're currently seeing continue through all of August, well, by the end of next month, you might expect to see that New South Wales first dose percentage be up closer to 60%.
As COVID cases increase, so does the number of people suffering long-term effects of the virus. Alexia Fisher is one of those. Alexia was living in New York when she caught COVID in March last year, and 14 months on, she's still feeling the impact. Alexia, good to have you with us. Take us back to how you came to be infected.
In March, when I became infected, there was really no testing around, so the ability to contact trace in New York was non-existent. I couldn't even get a test at the time that I got ill, and subsequently I found out a lot of the people around me were ill and had contracted the virus.
Now, if you go back to March last year when you got infected, it was a time when people primarily thought this was a disease that affected older people. Did the severity of your condition take you by surprise?
Absolutely. I fell into the risk category, which was quite low. I was 33 years old, female, quite fit, and no pre-existing conditions. So I wasn't expecting it to hit me quite as hard. I don't think that I was being reckless in any way. In fact, I was quite cautious about the virus in any case, and I was wearing like masks, even though the recommendation wasn't to do that. I had some cloth masks, but I still managed to contract the virus, and I was in bed for around 3 months. So it was quite rough and scary, really.
And a year and a half later, you still got symptoms. This is what's thought to be long COVID. What does that look like day to day for you?
So I think one of the things that I can measure more readily is the fact that I can't smell anything, which sometimes works to an advantage, but I'm not saying people should go out there and get COVID to avoid bad smells, but quite literally I can't smell anything. I'd say I have about 10% of my sense back, my nasal sense. I can taste food, but the thing that really is quite frustrating is my lung capacity. So I will walk up a hill, quite a light hill, and be out of breath. So I'm definitely noticing that. And also at around 5 p.m. or in the afternoon, I find myself really exhausted, and I'm going to bed at like 6:30 every night now. So it's quite different to previously when I would be quite the night owl and be up till 11 or so.
For everything you've been through, what do you want people to know?
It's a good question, because every single day when I walk around, I actually really struggle with it mentally. When I see people that are unmasked in queues or they're just complaining about the situation, it's a very difficult thing to have to grapple with when I know how significant this virus is. I think the main thing is talk to your doctor. There's a lot of information out there that's currently changing, and fundamentally what is right for you is going to be on a personal basis, and you're better armed with the information.
Alexia Fisher, so good to talk to you. Thank you for joining us.
My pleasure. Thank you.
Let's bring in Nancy Baxter. She's a clinical epidemiologist and surgeon who heads up the School of Population and Global Health at the University of Melbourne. She joins us now. Dr. Baxter, thank you so much for joining us. What is the prognosis for someone with long COVID?
Well, that's a great question. And one of the challenges is we don't really know much about what happens with patients with long COVID, because, it's COVID's a new disease, and long COVID's, we have even less information about that. Alexia, in her description of her symptoms, it's pretty classic for what people experience. So when people have had COVID, if they continue to have symptoms for over 12 weeks after they've recovered from the actual infection itself, they're considered to have long COVID. But these can be a variety of symptoms that affect kind of many parts of the body. Most commonly, the things that she was talking about. So fatigue, just feeling very tired, feeling short of breath, chest pain, palpitations, and some people get something called a brain fog, where they just don't feel like they're thinking normally, and just are kind of fuzzy. And some people get this loss of taste and loss of smell.
And again, I want to press this point because it's one worth making again. This is not something that just affects older people.
No, not at all. In fact, the most common group that it affects is middle-aged. Middle-aged women tend to have the highest rate. Lots of men get it too, though, and actually about 7% of children, 2 to 11. The best place, the place that studied this the best is the UK, and they found about 7% of children, 2 to 11, who get COVID will have symptoms beyond that 12-week point. So this seems to be just part of the effect of getting a infection with COVID-19. It's unclear why people get it. And, it's not even clear if all of these people have the same problem. It may be that COVID causes a number of different problems, and they're all presenting, and we don't really understand it yet. So we just all lump it into a basket that we call long COVID.
And that makes it difficult to then treat, doesn't it? I mean, what does that do for the health system longer term when all these people start showing up at their GPs, at their hospitals with something called long COVID? There's
currently no clear treatment, and I think part of that is because we don't really understand what causes it. Likely to a certain degree, it's the immune system. So, the immune system has put up a big fight against COVID. It gets rid of COVID, so the enemy's gone, but, the army continues to fight, and it can kind of start affecting one's own body system. So what we call an autoimmune disorder. There's some thought that that might be part of it, but we really don't understand it.
Dr. Nancy Baxter, thank you.
Thank you.
Well, in Australia, patients who are severely ill with COVID are treated with a cocktail of drugs that are proven to work. But viruses are notoriously hard to cure, and COVID-19 is no different. 12 out of 100. That's how many lives are likely to be saved when the steroid dexamethasone is given to COVID patients on ventilators. 60 are likely to recover anyway, and 28 will die even with the drug. These statistics are from the world's largest clinical trial for COVID treatments, based in the UK. It's one of many trying to figure out which drugs work and which ones don't. It might seem simple, but oxygen is the main therapy. Oxygen saturation in the blood usually sits around 96%. If that starts to get below 93%, more is given through nasal prongs. And the steroid dexamethasone is given to patients who need oxygen.
When your body has an immune response to an infection, like COVID, it causes inflammation. We use the dexamethasone to reduce that inflammation so people can breathe easier.
The drug only benefits patients who need respiratory support. There's no evidence it's helpful before patients get to that stage. Dexamethasone is one of the 3 drugs being used to treat COVID patients in Australia, alongside remdesivir and tocilizumab. First developed for Ebola, the antiviral remdesivir stops coronavirus from replicating, so it's more likely to be useful early on.
It seems to be of much less benefit once someone's on a ventilator, because you're through that viral replication phase, and by that time, an antiviral drug isn't going to be as effective.
In a trial including more than 1,000 patients, the drug reduced the recovery time of people hospitalised with COVID-19 from 15 days to 11.
So there's no single drug that's most effective. What we found is we need to use a cocktail of drugs depending on the symptoms that the person's having and how far advanced their COVID infection is.
Tocilizumab is another anti-inflammatory drug. In a number of large randomised clinical trials, it's been shown to reduce the chance of dying by 15%. It's used for patients who already need oxygen. But there's one set of therapies we don't have in Australia yet. They're called monoclonal antibodies, and we don't have any that specifically target this virus. It's a man-made version of the antibodies that we naturally make to fight invaders. These drugs seem to work better in a pre-hospital setting.
If we give it at that really early stage, that reduces the risk of hospitalisation by about 70 to 80%.
And research shows they can also be helpful in hospital if a patient hasn't started to produce their own antibodies.
If you measure whether someone started to produce their own antibodies, if they haven't, then these monoclonal antibodies seem to be able to reduce the risk of dying as well.
And then there are treatments that don't work.
A lot of good things have come out about the hydroxy. A lot of good things have come out.
The anti-malarial drug that was hyped early on in the pandemic has been proven to have no efficacy against COVID-19. The results of 6 trials show the drug doesn't reduce the chance of dying and doesn't shorten the time patients spend in hospital. In fact, it even exposed patients to potential side effects, including heart damage.
The reality is that we've talked about lots of different repurposed drugs. The majority of them haven't worked.
The common antiparasitic ivermectin also seemed promising. Clinical trials are yet to demonstrate that it's effective against COVID-19. One study found that at high concentrations, it can stop the growth of the virus in a Petri dish. Unfortunately, many lab results don't work inside the human body. For the drugs that do work against COVID-19, their effectiveness very much depends on the right timing.
Dexamethasone may actually be harmful for someone who's not requiring oxygen. So if you gave that to every person in Australia who gets COVID, it might actually do harm.
It's all about giving the right drug to the right patient at the right time. Because so far, there's no silver bullet for COVID-19, though prevention is always better than a cure. So what's likely to work is a vaccine. And that is The Vaccine for this week. Bye for now.